Hello, good morning. Thank you very much for being here. And thank you to the organizers and for the nice introduction. So I will be speaking about virtual reality for pain relief. And we have all felt pain. So pain is a sensation that it has receptors in the nerve terminals that are nociceptors, and that actually, as a neuroscientist, when I started, I first recorded from these terminals how they encode the pain in the form of spikes or action potentials. And then these signals travel all the way up through the spinal cord to the thalamus and the cerebral cortex. And interestingly, not only they project to somatosensory areas, but they also project to cognitive areas like the prefrontal cortex and to areas that encode emotions, like the insula and the amygdala and so on. So therefore, the pain sensation is not just the mathematical translation of this encoding of pain, but is modulated by cognition and is modulated by emotions. And all this makes it a sensation that can be actually modulated by virtual reality, which is what I will be talking about. Another aspect that we need to take into account about the pathology of chronic pain is that it has very high prevalence, 20% in adults. Is also very expensive, very costly, not only for the direct medical cost, but also by all the productivity and work loss, 150 million in people. The current treatments often show small effect sizes, tolerance, and as you probably know, a big crisis of opioids, for example, in North America. So therefore, it's necessary to have other approaches, and it's demonstrated that multimodal approaches that combine also psychotherapy, not only painkillers, and so on, work best. And it's important to have other ways, like, for example, VR. Another aspect that is important to take into account about pain is its complexity. So, as I already mentioned, there are all these different aspects that are cognitive, emotional, for example, the association of chronic pain to anxiety, depression, social isolation, then cognitive effects like a decrease in the capability of concentration, and also other organic aspects like muscle contracture, inflammation, and so on. So it becomes this very complex entity that we know all that it can generate strange effects, like, for example, the placebo effects, and it's also affected by body representation. So it's a complex illness, and it's highly influenced then by perception, by expectation, by body representation. And indeed, one type of chronic pain that we have studied in the lab, but I won't be talking about this today, but it's a chronic pain condition that actually includes all these aspects that I mentioned, or many of them, which is fibromyalgia. It has a prevalence of 10 million people around the world. And it includes many of these aspects like body distortions, but also brain fog, depression, and pain that Justina Swidrak in my lab has studied. This is a representation of the very wide distribution of pain drawn by these patients. And there has been studies in the lab about how to use VR to try to cope with this disease, but it's a very complex one. So what can VR offer for pain relief? I have made this classification that I will present during this talk. VR can be used to reduce the attention to pain, to decrease the associated anxiety. Embodiment in VR can be used to modulate the pain threshold and to modulate eventually chronic pain. And then I will mention some recent combined or multimodal VR approaches that we have used, and also share virtual spaces for patients. So it will be brief in this section. So I will start with VR to reduce attention to pain. So when we enter a virtual environment, we enter a different world, and therefore we decrease the attention to our body and to to the space in which we are. And this actually can reduce pain, and this was used from the late 90s by Hunter Hoffman and collaborators, where they used it with a condition which is very painful, which is the burn children, that they have these bandages changed, and then this is a very painful procedure, and they created this snow world where not only one can get immersed, their brain can recreate the cold, but also they are distracted, is interactive, and so on. So this actually demonstrated not only decreased the pain sensation, but also the pain as measured in brain imaging, the pain signals in the brain. So we have also, although we haven't really studied in my lab the role of attention in pain, but we observe that often just the fact of being in virtual reality decreases pain, apart from other strategies that we may use. So this reduced attention to the body and to the current environment, it works. And it's important to include it in some multimodal strategies, as I will show later. And if you are interested, there are very highly cited reviews discussing the role of attention in pain. So VR can also be used to decrease the associated anxiety that goes along with chronic pain, as you can imagine. And there are many VR applications that are designed for relaxation, disconnection, meditation or guided meditation, mindfulness, and so on. And they are available because it's a good system in order to decrease daily life anxiety. And actually, we have used it in a multimodal approach that I will show you at the end, which is where we use this, sorry, somehow the video is not running. So anyway, we have these sessions where there is either relaxation or some meditation that can be used after doing some kind of other strategies to decrease pain. And actually, Benyata Mestoy in my lab has studied the mental health effects of a multimodal virtual rehabilitation programs where we have detected reduction in the feelings of being downhearted and blue, feeling calm and peaceful, and this improves after 3 weeks of treatment. So this is a part in a whole system to treat chronic pain. So therefore, this is also another aspect that we need to take into account when using VR for pain. It can decrease anxiety and stress. So I will now talk about embodiment in VR to modulate pain threshold. And some years ago, we started studying embodiment of virtual bodies. And yeah, somehow with the projection, the videos don't want to run, but
sorry, always demo effect, so last day it works.
Okay, so we studied how visotactile correlations or visomotor correlations, and probably all of you are familiar with, they can make us feel that a virtual body is our own. So therefore, we can feel not only an arm, but a whole body as our own body in virtual reality, and we wonder to what extent we could use,
okay.
Yeah, thanks. So to what extent we could use the virtual body to modulate the pain threshold. Okay, I don't really need the videos. So yeah, so they move a bit slowly, but it's okay. So yeah, we did the visotactile correlations, sorry, this is what I need is to move the slides. Yeah. Now they got blocked. Yes, so we wanted to investigate to what extent our virtual body can be useful to modulate the pain threshold. It's not moving to the next slide.
Okay. Sorry for that, always demo effect. Where were you? Sorry.
You want to go to my slide?
Yes, I will. It's always demo effect, you know, try everything and then.
It's okay.
Sorry for that.
Yeah, but it's not moving to the next
Yeah,
slide.
I think it's. Okay, so let's do a technical break. Sorry for that.
Maybe just the HDMI is fine.
Yeah, I will just close the. I save?
No.
Because it happened to me yesterday.
I'll open it first. No?
See if I could old school reboot. Please.
No, let me remove this.
Yeah, I mean, it's, just want to. Selection techniques. Okay. This one?
Well, I just want to be able
Okay,
to
now I
move the
think this
slides.
is working.
No, you think it moves to the next one?
Yeah, no, just go with your keyboard. Just.
Okay, a bit of excitement. Yes, so sorry about that. Yeah, so we started working how to induce embodiment in virtual bodies, and yeah, we found that with visotactile correlations or visomotor correlations, we could feel a virtual body as our own. This is a correlation between the subjective feeling of embodiment and the objective measurements of embodiment, and therefore it's well known by people here that one can feel a virtual body as their own body. We use correlations, we use first-person perspective, and so on. So, as I said, we wonder, can virtual embodiment of a virtual body modulate the perception of pain? So we knew there was a paper by Longo et al. Showing that if you look at your real body, your pain threshold increases. They tested this with an infrared laser, and basically, to make a long story short, what happens is that when you are looking at a part of your body, you feel less pain. There is like a local anesthesia. There is an interaction between the vision and the tactile processing. And this is not only in the reported pain, but also in the responses in the brain. So therefore, if you are looking, for example, if you are going to get a blood test, it's going to hurt less. This is the observation. So we wonder, would this happen if we feel as own a virtual body? And we did this in healthy people, and all this block, I'm going to be talking about pain threshold in healthy people. And in order to measure this, we borrowed from the hospital, from our hospital, the thermal stimulator or thermode. That is a medical device that is used in clinic because it's necessary to measure the pain threshold in patients that they may have a nerve damage, because, as you know, pain is also a protective measure. It protects us from getting burned or from getting injured, and therefore, in some pathological conditions, there is an alteration of the pain threshold, and this is a problem as well. So we had this, and we could measure, therefore, in which moment of stimulation with heat, healthy people without chronic pain can feel pain. And then we investigated a number of conditions embodying a virtual arm and comparing it with a correlated tube or with a condition just from being in VR. And we found that actually the phenomenon was very similar to the one with the real body. Looking at the virtual body actually had an analgesic effect. And this didn't happen just by being in VR. So therefore, there is this effect that can be reproduced with the virtual body. So So there was at this time some kind of debate because with the rubber hand illusion, it was found that this analgesia effect didn't happen, and we measured to what extent was because there is no co-location. Obviously, with a virtual hand, you cannot be in the same space, but with a virtual body, you can. And we found that actually analgesia increases when there is co-location. So therefore, you can use the possibility of having your real body and your virtual body co-located to get this kind of analgesic effect. We also studied how it affects to change the skin color, for example, and we found that when your skin color in the virtual arm is red, your pain threshold decreases, there is more probability to feel pain, and this doesn't happen if the red color is outside the body. So therefore, the color of your virtual body can modify the pain threshold. And then we studied transparency. So I'm interested in all these aspects that you cannot do in the real world, and in the real world, it's difficult to make your body transparent. And one thinks, if I have pain in the hand and my hand becomes transparent, is the pain larger or smaller? So we found that by measuring the pain threshold, actually there was an interesting relation with transparency, such that it's contingent on ownership. So the more you own a transparent body, it decreases the pain threshold. So in all these cases, with the vision interaction, it's very related to prediction. So if you can predict very well where pain is going to occur, you can resist pain better. But if your body is transparent, somehow the prediction is worse and the pain threshold lowers. So there is a relation, and there is, most important for this, there is an effect of body transformations on the feeling of pain. So therefore, we found that seeing a transparent body is less analgesic, skin colors affect pain threshold, and so on. So we were interested at the end to see what happens with patients with chronic pain, and then we started working with them, and we found in the first study with a single case of a patient with chronic pain. He had a dystonia and complex regional syndrome, and his hand was closed in a fist for several years, and then we put him in VR, reproduce his position, then give him with BCI the capability to open his virtual hand, and he found a great relief, and he found very well by being able to do this, it decreased his pain and so on, and therefore we thought there is this possibility of work with VR, and we have tested different strategies. I'll go a bit fast. So we have tested transparency, we have tested the effect of size, and done this with patients with different entities like a complex regional syndrome or peripheral nerve injury. And first of all, an interesting conclusion from this is that people with chronic pain could experience body ownership. They can own a virtual body. This was a question for me because I wonder if you have pain, maybe you are so grounded to your real body that it's going to be difficult to embody. But actually, even in patients with fibromyalgia, we can see that with chronic pain, it still is possible to embody a virtual body. And then we can study which transformations can have an effect. And we saw, interestingly, that while in healthy people, making the body transparent was less analgesic, actually it worked with people with complex regional syndrome. So what this tells you is that not only you can predict what happens in the healthy with what's going to happen with patients with chronic pain, because their brain has been changed because of the pain, and therefore they may respond differently. So actually, transparency worked well for a set of patients with complex regional syndrome, and this was not the case for patients with peripheral nerve injury. And this tells you another conclusion, which is that for different etiologies, we may need different strategies, and it's important to take this into account. So far these bodies were static, but we have tried also with dynamic movement. So in patients that had limitation of movement of the shoulder due to pain, we gave them a body, and without moving, they observed movements of their virtual body for a period of time. And then we found that just by seeing after embodiment these movements of their virtual body, actually they improved their movements with respect to the pre-treatment. So they improved their shoulder abduction and the hand behind their back movements. They improved them just after one session of VR. However, at 1 week, this was not maintained, and of course it was only one session, but this tells us how can we prolong these effects afterwards. Now we see that doing it for longer periods of time actually can be the answer to this problem. So therefore, chronic pain patients can embody a virtual body. Pain can be modulated by transformation of movement of the virtual body. And the strategies to work to modulate pain threshold in the healthy may work differently in patients with chronic pain, and there may be a specificity of strategies. So far I have been telling you very specific manipulations because we wanted to understand mechanisms. So to what extent we can change the color of the skin, or we can change the transparency, or we can change the size, or we can change we can have movement. But then if we want to give something to patients to work with, we want to try to increase at the most the effectivity. So we have tried recently with a project called XR Pain, Extended Reality Assisted Therapy for Chronic Pain Management. We tried a combination in order to treat low back pain. So low back pain is very common. Most of people experience it at least once in life, and it's a condition where many people could benefit from rehabilitation. And we've done a clinical study that is planned with 100 patients. We recruited 95 so far, and they have finished like 90 of them. So it's for home use for 3 weeks. We have lookalike avatars. This is based on embodiment. There is a virtual physiotherapist, and we combine here a number of strategies. So not only one like in the previous studies, but a combination of strategies, different levels of intensity. So we have a package with education, or with different types of exercises, games, and then relaxation, that as I showed you earlier. So therefore, it's a combined strategy, and we don't have the final results yet, but this is from interim analysis where we see that the pain interference score with the daily life activities is decreased after these 3 weeks. So we don't know to what extent this will be at the end with the whole population significant or not, but we know for sure that we have very good feedback from patients, and some of them even they said they left drugs that they were taking. It decreased their fear to movement. They started having more activity in the real world, and even proof that they liked it is that many of them wanted to buy a head-mounted display and get the software installed. So at least for some patients, it really is good to have a change in their chronic low back pain. So finally, even when I have 1 minute, right, for this, because there was the problem. So I will just tell you that we have used, actually with these patients, we have used shared virtual spaces for focus groups, because when you give one of these systems to patients, of course, the usability aspects of medical devices in general are very critical, and the feedback and the co-design with patients is very important, because often they detect problems of usability that you don't detect in the lab. So therefore, it's good to get their input, and actually we were doing focus groups with them to see where the problems were and so on. But then in the lab, there is a system called VR United that is being developed by Ramon Oliva and other members of the lab, where it's a shared virtual space with lookalike avatars where up to 12 people can meet. So because these patients had their systems at home, their lookalike avatars, we decided to try to have these focus groups where we got together with the patients, researchers, clinicians, developments, and then they reported about their experience with the rehabilitation program, but also it was for us a test to evaluate whether it was possible, it was feasible to have these group meetings in VR with these people that they are not like experts in using the system, so they need to follow some instructions. So I won't show you the many quantifications, but in general, they could do it. They really enjoyed it. It was very nice. Of course, there were glitches also. And as you can see in the last one, after 90 minutes, I had headaches, said one of them, because sometimes, as you can see, it was very long, and then it became heavy and so on, the head-mounted display. But it's really completely different from having video conferences. They enjoy also to talk to each other with people that share their problem, and they gave us also valuable feedback about the device. So this is another avenue that I think is interesting, to have these shared virtual spaces for groups, for meetings with patients and between the patients and with clinicians, but also developers and so on. So we have one paper published on this and one coming. So with the conclusions, I won't go into them because I just gave the talk and I told you some conclusions already. We have some reviews, but there are many interesting open questions like how to prolong effects outside VR, how to map strategies depending on the cause of the chronic pain, how to combine more effectively strategies. And something that I think is very important, and this is a good forum to discuss, is the need to have larger multi-center clinical trials, because there are many small studies in many different labs, and somehow this is not becoming yet standard in the use of the treatment of pain or other medical applications of VR. So I think it's important to discuss this possibility of having multi-center clinical trials. And then finally, the last one, how to get these tools to patients. We find many limitations, regulatory, and somehow it's very common to just have prototypes that never make it to real products in hospitals in a systematic way. So thank you very much for your attention. Thank you to all the collaborators and funders, and especially to Tony Donegan, who is also here and has a poster today. And thanks.